Stanford healthcare medical interpreter, and that's when I became very interested in sort of cross-cultural care in interpreter mediated contexts. Over the years, as I wade into cross-cultural care, I became more interested in sort of how culture is understood and negotiated in health contexts. And so my research focus has shifted more into sort of the larger, broader understanding of how different cultures can be understood and how can we understand human behaviors, provider-patient communication in this context. Um, Historically, when we think about culture in relation to communication, we often think about, we don't think about culture is fixed. But the way we talk about we tend to do a group-based approach, right? This is how Chinese people talk. This is how Japanese people talk. And so it becomes fixed to specific groups, and this is their pattern behavior. This is how they think. But in that sense, then culture becomes a fixed quality that is attached to a group of people. Alternatively, sometimes we think about culture that only patients has culture. I need to learn how to talk to Hispanic patients. I need to know how to work with deaf patients, but we don't really think about doctors having cultures. But the reality, especially in the United States, is that 40% of the physicians that practice in the United States, 40% are trained outside of the United States. In other words, these international medical graduates, they carry their own culture with them, but we never think about how doctors culture, right? We think that patients, regardless how long they live in the United States, as long as they're Chinese, they'll be influenced by their Chinese culture. But we don't think about how Chinese Chinese ethnicity American doctors who practice in the United States for 20 years, are they still being impacted by their own cultural views? And how does that influence their communication with their patients? Finally, we often think about culture as a caveat and a noise in the way we practice medicine, or even when we think about communication theories. So we'll say this is how people communicate. But remember, if you talk to Chinese patients, if you talk to Japanese patients, they act differently. And so in that sense, then a culture is a deviant. Like, you have to be attentive to the differences, as opposed to culture actually grounds everybody's thinking and behavior. So in this my latest book, 2021, that I wrote initially, I was planning to finish it in 2020. It was a little bit late, so I wrote to my publisher and said, can I delay my work to send the manuscript to you probably by February, March 2020? And that was exactly when pandemic hit. So I said, can I delay it to like July? Because I need to rewrite my whole book. um, but in this book, I try to think about how culture influence the way we communicate and talk in terms of health behavior, how they influence our health decision making. I want to highlight two aspects of culture that I talk about in class in the book, and then also um, based on that foundation, I wanted to later talk about sort of the cultural framework I lay out in this particular book. So the foundational understanding is that culture applies to everyone, including doctors, including patients. It is not, it is more than a group-based understanding of behavioral patterns, and it provides a foundational frame for us to understand our reality and through communication. And throughout the talk today, I hope that I can bring you sort of a glimpse of, what do I mean by that? First, we rarely think about how culture is influenced by the speech communities that we're in. But one of the examples I think is very clear in helping healthcare providers to understand how our culture, our own personal culture, influence the way we practice medicine is if you look at the gender disparities in treatment and diagnosis, then it's a good way to think about how our understanding and stereotypes of how men and women talk would influence the way we treat our patients. So everybody knows that there is gender disparities in pain management, right? When women cry and they say, "I'm in so much pain. My pain is in 1 to 10. It's 10. It's unbearable." Doctors are like, "Well, women are a little bit emotional. You're probably just experiencing 6 or 5, but being that you're a woman, you cry. So, it's understandable." So women are undertreated with their pain. But when women realize that crying discredit their narrative, right? When doctors don't take them seriously, they try to be stoic and say, "My pain is serious. I experienced level 10 pain." Doctors were like, "Yeah, but you're not crying. A woman who's truly experiencing level 10 pain would have cried, and you didn't. So you're really experiencing 6 or 5. You're just trying to, you know, convince me even when you don't really feel the pain." On the flip side, when the gender stereotype, when we think about how men communicate their pain, if they're crying and they say they're experiencing 10, we think that they're experiencing 11, right? Because it takes that much for a man to start crying about their pain. If they're stoic and they say, "I'm experiencing 6 and 7," you're thinking, well, they must be experiencing 8 or 9, because men tend to suppress their pain. They don't want other people to think that they're weak. So because it's not because they are poor communicators. Historically, when we think about, well, women experience health disparity in pain management, we need to train women to communicate better with their healthcare providers. But if you think about this, the reason about their disparities in pain management is not because women are poor communicators. It is the cultural context that discredit women's narrative, and we're all influenced by it. And as a result, it's the how we understand men and women talk that lead to the healthcare disparity. Women can try and try; they're just not going to be perceived credible in sort of this normative social context that we hold. And this also speaks to how women experience like disparities in their diagnosis of heart attack. When men and women both reported symptoms of heart attack, but then they also report stressful life event, divorce, difficult situations in their life, men's report of stressful life event does not influence the likelihood that they are going to be diagnosed with heart attack, or but for women, if they report stressful life event at the same time when they report um, heart attack symptoms, their report are often discredited. And so they ended up treating them, not diagnosing their heart attack symptoms, even though women are more likely to have heart attack than men at this point. Their reports are discredited, and therefore, like, they're underdiagnosed when they're experiencing heart attack symptoms. Similarly, you see these kind of referral patterns. Women are oftentimes double and triple their pre-referral visit to an oncologist in their bladder and renal cancer diagnosis, because their report about their symptoms were not taken as seriously as those of men. And this is not a result of women are poor communicators. Normally, we think that women are great communicators compared to men, except that when they're in this healthcare context, we think of them as how do women talk. The way women talk and the way we understand them ended up discrediting their narratives and creating health disparity for women. So so this is a situation where, a typical group-based approach to address women's health disparity would not have worked, because the problem is not the female patients. The problem is the society as a whole, which also include doctors and nurses, hear females patients versus male patients talk differently and ended up making different decisions as a result of it. Similarly, uh, culture, we tend to think like, we don't think about it as a element that is constantly negotiated, enacted, or often exploited. How can we exploit culture? That's who we are. But if you think about how informed consent works in Western bioethics, right, biomedicine, bioethics, we think that informed consent tied to all kinds of foundational value we respect, self-determinism, patient autonomy. Um, these are values, body integrity. These are issues that Western culture embraced because we respect a person's control over their own fate. It's even enforced by law, right? When informed consent wasn't done right, but doctors can get into trouble. However, because our value in sort of protecting patient autonomy, wanting to make sure that they are informed in their decision making, you start to see a lot of states, right, using our value system, our desire to have the most comprehensive, most informed consent possible to manipulate patients' decision making. You have compelled disclosure laws in a lot of states where it required the doctor to inform the patient. Many women experience tremendous depression after they had an abortion. They demand that women hear the heartbeat of their fetus before they decide to choose abortion. So these are interesting ways where, under the guise of our cultural value to respect and honor and protect informed consent, we manipulate it in such a way that we coerce patient decision making. Similarly, this culture appreciate religious freedom, right? We want to protect that. So much so that we allow Catholic hospitals to create policies that tell their ER physicians that they are not allowed to discuss emergency contraception even with rape victims. I think there's a recent survey that says 74% of Catholic hospitals have these policies. So what do you do if you're a physician working at a Catholic hospital? We are compromising care, but the doctor may not agree, right? So what you see from these places is that, the doctors by hospital policy are prohibited to discuss these issues. Some doctors would say it regardless. Other doctors would say, we'll find another social worker or a different person who can talk about these issues. And then some other doctors will tell their patients, like, well, because I work in a Catholic hospital, I cannot talk to you about these policies. And so, you know, and so I can't answer any of the questions. If you are interested in emergency contraception, you just have to talk about it with somebody else. And in an interesting way, like the doctor follow the policy, but also figure out a way to tell the patient that there's another option that I'm not allowed to talk about. So in that sense, you start to see that the doctor is maneuvering the cultural ground of following one cultural value, the Catholic hospitals expectation of we don't uh, you know provide consultation about emergency contraception, at the same time, following doctors' moral expectation about what does do no harm means and how can I help the patient without violating cultural rules. So from these perspectives, then I start to think about how these different cultural understandings will impact the different type of solutions we have, right? If we think that women is a poor communicator, the solution we would have is to develop a lot of training program to teach women how to communicate effectively. If we think that the problem is a cultural understanding and stereotype about speech community, we would create a different type of intervention and solution to address these issues. So from this perspective, I start to argue that we need to look beyond a group-based approach to address cultural issues in healthcare settings. We need to recognize that some of these cultural behaviors, even including Catholic hospitals' desire not to inform their patient rape victims at ER about the availability of Plan B as a emergency contraception is tied to these hospitals' value-driven decision making, and that we need to be careful about how these um, utilization or exploitation of our cultural values can turn around and work against the actual values we hold dear, or the object quality of care that we want to protect. So in the book, I proposed a cultural framework that was um, based on um, Dr. Eric Kramer's dimensional accrual and dissociation theory. Basically, we ended up providing three cultural framework, and the fourth cultural framework is sort of integral fusion, is a mixture, a blending of the first three. So there's magic consciousness, mythic connection, and perspectival thinking. I will just discuss these each cultural framework a little bit, and then I will apply it in social support context so that you can see how these different cultural framework influence people's understanding of reality and how that impact their decision making and health behavior. So knowing which cultural attitude a person holds, so whether it's your patient or whether whoever you're communicating with, allow you to understand why they are not changing their decision making, or why their reasoning and rationale work in specific ways. So for magic consciousness, it's a taken for granted reality. For mythic, it's a value-driven reality. And perspectival thinking is super analytical, cost effectiveness. Nothing is sacred. Everything can be negotiated, measured, and trade. So let me get into, I'm going to use the social support as an example to talk about, to sort of, in the back end, I'll tie all of this together. So what we know about social support is that perceived social support, how much I think social support I have, is more predictive in health outcomes than the actual support that people received, right? That doesn't quite make sense. How would the imaginary social support be more effective than the actual social support I received? Second is for 30 years that researchers have been trying to figure out why, if the support you need matches the support was given, will predict the best outcome. And at this point in the literature, we can easily say that that hypothesis doesn't hold up, which also is confusing, because if I need A and you give me B, wouldn't, as opposed to A, wouldn't like receiving A be more predictive to my outcome, like happiness, positive outcomes, as opposed to giving me something that I don't need? But somehow matching hypothesis was not supported after 30, 40 years of research. Finally, invisible support, that support that we receive but we don't even recognize we receive, provide the strongest benefit, which again, kind of confusing, because if I don't even recognize I'm gaining support, how can I have the best outcome when I know there are lots of people loving me and trying to take good care of me? Finally, fit pay it forward is a set of research that researchers find the more you give, the more energized you are, which again contradicts with what we know, because we have tons of studies that talk about how caregivers feel more drained after their caregiving act. So how come when you buy a cup of latte and then paying $30 for the group behind you make you happier and more energized than paying $5 for your latte, right? So what I want to argue is that cultural consciousness help us to interpret the functions and meanings of social support. And that's why they have these different outcomes: the availability of social support, the implication of what does it mean when we give and receive social support. Magic consciousness is, we do this is because this is who we are. So when you need to lift up a car to save a child, people do it. They're not calculating. When you have to jump into the road to save your daughter, you don't go like, but I have two other daughters I need to take care of. I can jump in front of the street to save this one. You're not calculating, you just act. Because at that moment when you're offering support, you're acting as one. That support is unreflective, it's taken for granted. In that sense, for people who hold magic consciousness, they don't even think that they're giving support. When your left hand help your right hand, you don't think your right hand is helping left hand. When you help out your child, you don't think that I'm helping out your child. You think that we are going through this together. So in that sense, if a magic community is very powerful, because then whatever the community norms is, it dictates the kind of support that will be offered and that will be taken. And so here's an example of magic consciousness. Magic is powerful because mom is not doing shaving her head to say, I support you. Mom is shaving her head, and both recognize at that particular moment that we're going through this together. Your cancer is my cancer. Your journey is my journey. I love this clip a lot, especially when I'm talking about magic consciousness, is that I don't understand a word that they're saying, but I recognize that emotion and I connect to it immediately. At a primal level, at a fundamental human level, we don't need language to see and recognize when a magic moment is happening. And these acts are not symbolic. It's not, it is what it is, that we're going through this together. There's no separation at that moment between the mother's journey versus the daughter's journey. It is experienced as a whole. You are the one and the same. In contrast, so the reality is transformed, right? As mom shaved her head, it's not it is we are one together immediately. And so for people who holds magic consciousness, then they have strong unreflective bond to one another in that particular community. They're not separated. One is all. Maybe like Mandalorians, relationship is taken for granted. You don't distinguish your identity's desire. Whatever happened, if your daughter or child is harmed, you are harmed. It's not like, I am angry because my daughter was hurt. You are hurt. And that's a different level of understanding and connection. But for people in magic community, then the worst thing that can happen to them is to be ostracized, to realize that you are not part of us. And so these people are highly then motivated and sensitive to in-group, out-group divide. Anybody in the out group could not convince them otherwise. And we kind of see that in the COVID narrative, right? That dying is not a sacrifice. dying for your cause, for the belief of in-group member is an honor. It's taken for granted. You don't even think of it as an honor, like when you jump out of the street to save your daughter, you don't think, oh, I'm gonna be a great mom. You think that either we live together or we die together, and if we die together, it's fine. There's no sense of loss. It is fine. However it turned out, either we live together, we die together, we recover together, it's all fine because we are together. And you see that in parent-child, in terms of health behavior, you see that parent-child organ donation. But you also see how these people, then they are willing to die, even though, they know they could die without a vaccine, but that's fine because I am this is what we do. We don't accept that. What is interesting then is for these people, you start to see there's no way of convincing them otherwise, right? And there may be some mythic people who understand that this is really not good, but if I choose to get vaccination, I'll be ostracized by my group. And that's a bigger punishment than me not getting vaccinated. And so as a result, you start to see them like trying to disguise themselves to get vaccinated. But the last thing they want is to be known that they are, a non-believer to their magic community. For Mythic Connection, the idea is that these are value-driven communities, right? This is symbolic communication. So their shared identities encourages support provision. It becomes there's a distinction between sort of, whereas magic, there's no distinction. We are all in this together. In mythic communities, they support the same cause and they're willing to sacrifice for their cause. And they use these values to develop cohesion and community behaviors and health behaviors. So in the context of COVID, you see doctors say, you stay at home for us, we stay at work for you. We both are making sacrifice for one another, but it's for the better good. In these situations, then the support prioritized to in-group members. We want to, protect the value we appreciate. And so these acts are not transformative. Like when I shave my hair, it doesn't act like I am in this journey with you together in the literal sense. But nevertheless, it speaks volume about the type of values, that the community strive to protect and honor and guide individual behaviors. So you see these kind of activities, right?
Well, it's such a great cause, and for me, bald is beautiful. So to come out and be in this community I grew up in, got married right down the street. So it's very cool for me to do that. All these people here with green shirts on, cutting their hair for such a great cause, are true heroes. Get a chance to see some of the kids and try to brighten their day. It feels great. It feels, obviously I'm not a doctor. I can't be in there trying to help with treatment and things like that. But if I can come in and brighten someone's day, then it's worth it. When I was in New England, I did a lot of visits like this, and it just means more when you're in your own community. So it's good to get out here, and really, all these people are getting their hair cut for someone they knew who has cancer, and really, my uncle's undergoing some treatment today, actually. So he's who I'm getting my hair cut for. So it's just good to be involved and get out in this community.
So what you see is that even though both are sort of shaving head to support somebody else, right? These magic and mythic is quite distinctive in the way it operates. That mythic, you see a completely different feel. It's a celebration of community and community value. It's not about we are one. Nevertheless, these shared value binds people together as a group. So these people's identities and desire to individual desire and behavior may be different from the group values, right? Nevertheless, we are all motivated to protect it and to say, I'm a good mother, I'm a good person, I am a good citizen, I'm a good community member. And in order to claim the goodness, there may be some sacrifices I need to make. So unlike magic, where they don't really understand, they don't really differentiate sacrifice and support, because it is what it is. There's no take or uh, there's no giving or receiving. Mythic does have some understanding of that, but they recognize that this is for the better good, and they are more than, when they act in self-sacrificing ways, they are also gaining and benefiting from community ways. Stories share and enforce the shared values. These people are willing to engage in self-sacrifice for the greater good. So when in during the COVID, these two charts could not be more different in terms of how they're acting. But what they're saying is the same thing. These both are mythic values that is being communicated, that these people are willing to die for a cause or to self-sacrifice for a cause. I will die before I comply with tyranny is a value-driven narrative. And so if they think that accepting a mandatory vaccine is the imposition of tyranny, then it's not that they're so stupid they don't recognize not getting vaccine is going to get them sick or take on personal risk, but that they are self-sacrificing for a cause. So wearing mask despite discomfort or getting vaccinated when even perceiving risk to protect others is just as the same as refusing to wear mask or getting vaccinated to protect individual autonomy. So here is what I was trying to say, that magic and mythic look quite different in practice, and you can spot it because the way they understand these supportive behaviors are different. In contrast, perspectival thinking this is what's needed. And so it's typically a cost benefit analysis. Support is a transactional mechanical process. It's an exchange of personal interest. In that regard, then we are feeding whatever the person's self-interest is, that as long as they agree that this drives my interest, they will be willing to change behavior. There's no loyalty to groups nor loyalty to values. They're kind of whatever self-interest is driving their decision making. So these are people who will come out and get vaccinated if you have big enough check or big enough lottery for them to win. These people are least likely to be impacted by social norms, capable of invoking social norms to, however, on the other hand, they're able to invoke social norms to exploit others' behavior and for self-interest. So in terms of health behavior, like I said, getting paid for COVID, for them to change their mind is totally fine with these people. They're willing to get vaccinated and wear masks when convinced by evidence-based research. So it's more about sort of cost-benefit analysis. If you can convince them, they can change their mind. And in many ways, we are perspectival people. Researchers are perspectival people. We don't have faith in a theory, right? If you show me the evidence to show me that my theory is wrong, I'm willing to change my perspective 180 degrees, no problem. Traditional public health approach, we tend to approach it from a perspectival thinking perspective. So what you see in our public health theories, health communication theories, oftentimes it's based on cost benefit analysis. We need to reduce barriers, increase incentives so that people would choose what they need to choose. Yeah, even in community-based approach, then we think about let's address the specific normative belief or social behaviors and reduce the barrier again, right? So that they would be convinced by our information that this is really good. But what COVID showed us is that this traditional approach doesn't work. Why? It's because these are social norms are influencing individuals' behaviors, and it's not just on sort of a perspectival thinking approach. We start to see magic consciousness and mythic behaviors emerging in when people are making their health behaviors. And what is particularly interesting is perspectival thinking, because they are very calculating, and so they can be very strategic, and they are able, because it's a dimensional accrual, so also perspectival people can recognize the magic element and mythic element that is influencing other people's behavior. In contrast, a person who is fully magic could not understand a perspectival reasoning, because it is what it is, right? Telling me that jumping in front of the street to protect my daughter, first is I'm not even thinking I jump in front of the street. Two is, even if you tell me it's not worth it, I'm not doing that calculation at all. But perspectival thinkers are calculators, and sometimes they are cynical thinkers. So they are driven to manipulate communicative process for their self-interest gains. So you can start to see non-believers relying on value narrative or other mythic communities, or identity appeals for magic communities to encourage behaviors. And Mohan Dudas talk about how cultural sensitive campaigns are problematic, because we sort of manipulate cultural values for campaign gains decided by the researcher. The magic and mythic community did not have a say in how these values and narratives are constructed. And so Honduras promoted sort of a culture center approach as opposed to cultural sensitive approach. Perspectival cynics are the people who are able to, perspectival people always know what they want to get, and they're able to transform their messages by talking to different groups of people to encourage the behavior that they desire. Magic consciousness, um, for people who hold magic consciousness, they don't dissociate from one another, right? So the between this, what they say is what they believe. And in this particular sense, COVID vaccination equals death is true to them. A perspectival person will be like, no. But I think for a magic person, they are thinking like, I may be alive, but I'm dead. Like, to live without freedom is no living at all. Is, for a magic thinker, is to understand it in a literal sense. I may be breathing, and the best way to think about it is probably Avatar, that that you are still alive, but you are really not. You're just a zombie living in this world. You have lost the essential thing that holds your identity, and as existential, it becomes an existential threat to you. So for magic consciousness, it is empowering for these people, because they are one and all, right? So they don't make decisions for themselves, but that doesn't mean that they are lost. They are very comfortable where they are. And risky health behavior, if this is the community norm, engaging in these behaviors make them feel that they belong. It becomes identity strengthening type of behavior. So, one time there are studies about homeless people, and they share needles, and they say, that's bad, right? They said, yes, but by sharing needles, I'm showing trust. This is what we do. If you say you don't want to share needles with my group, that means that you're an outsider. And I don't want that. So these behaviors are for about identity performance. It's about strengthening community bond. For mythic, because they're driven by their values, so you can't really, the way to convince them to change their health behavior is to change their community alliance. So if a person who's a mythic behavior, who says, like earlier, like I want to protect myself from tyranny, so I refuse to get vaccination. Maybe the idea is to transform the mythic alliance to family. So you start to see a lot of PSA talking about, you have your cultural belief, political belief, but you also have responsibility to your family members, to your grandfathers. And so it's an appeal to another community to say, are you able to transform from a mythic community to your political alliance to the mythic value of your family obligation? And if they're able to shift from, I'm a GOP member, or I'm a, my party doesn't like vaccination, to I'm a father, or I'm son of elderly parents, that shift will then transform the kind of social obligation that they're willing to follow. So due to shortness of time, I want to sort of very quickly wrap this up. right now what we're facing when we're communicating with a large group of population, I think, is because historically we think that everybody is perspectival thinker. We can influence them by their decision making by information. But once you recognize that people's health behaviors can be driven by their identity or their cultural values, with identity magic, cultural values, mythic, then you start to realize the way we communicate with them has to be different. That we, an integral fusion is in the book, I recommend it to be a way to approach it. It is to recognize that health behaviors involve both individual's identity and existential reality. You have to be able to find ways to appreciate it and to find a flexible, adaptive strategy when working with different types of population. It is to be reflexive about your ethical stance. And so for an integral fusion, unlike perspectival thinkers, where you're just using other people's cultural belief to manipulate their behaviors, I think the challenge of integral fusion is, on the surface, it may look like you're trying to understand and like they may look the same, but in reality it's a very different cultural value. For integral fusion, it is to understand and appreciate that different cultural values are equally valid, and there's no manipulation is not a type of thinking in integral fusion. It is about trying to understand. So when we think about, DEI, diversity, inclusion, uh, this is what DEI is about. It's a layer understanding to find a mutually agreeable frame for all, as opposed to, trying to exploit other people's cultural belief so that they agree with what you're trying to do. Your understanding of the other person's perspective and needs is essential to a successful support provision. So how does that fit? All the social support, how does that fit into the understanding of magic, mythic, and perspectival? In magic and mythic, social support is not a zero-sum situation. Giving support means that you are community members. It energizes you. Community is essential to your understanding of how you choose to offer support. Support is secure through in-group identity. Cost is irrelevant unless you shift into perspectival thinking. So what does that mean? Under magic and mythic, it is the meaning and the act of support that matters, not the quantity. Because so once you understand, like, your best friend is broke and they can't offer you the money you need for the rent before you become homeless, but they are there for you, they talk to you every day, that support means just as much, and even probably more, than somebody who give you money and doesn't care about your well-being. We appreciate the meaning of support even when it lacks utility. Under perspectival thinking, you know receiving support make you feel you owe somebody, and so if you invisible support kind of then ended up giving you the best benefit, because you're enjoying the benefit of social support without feeling that you owe anybody anything. What is interesting then is pay it forward. How does pay it forward work in our typical capitalist society, right? Why would I want to pay $30 for the car behind me when I only buy a $5 latte? Why is it that everybody had a sigh of sort of, you broke the chain of pay it forward? It is because as we engage in the pay it forward activity, we are in fact creating a community. We are no longer an individual. So in that sense, even though you may lose more money, but you belong to something bigger than you are. And it's in that connection that $30 latte make you happy all day, because you feel that you belong to a magic or mythic community that you just happen upon you. And so that is why pay it forward, they start to see where support givers become energized, support communities become energized as a whole, not just the recipient who gains from it. So proposition of the cultural framework is that culture consciousness is not fixed, though one cultural attitude may dominate one's behavioral thinking. Shifting can happen unconsciously, intentionally, or strategically. Intervention requires us to understand the cultural attitude that your audience is holding in order to understand how they understand their reality, right? We often think that they just need more information, but for magic and mythic people, more information would not change their behavior. Integral fusion offers the best opportunity to address conflicting cultural views. That's all I have for today. Thank you.
Thank you. That was fantastic and very thought-provoking. And I feel like I need to, actually, I did purchase your book and now I need to go back to really read through it carefully again because it's, I'm just seeing so many of these kind of looping ways of justifying oneself and behaviors that I encounter all the time doing palliative care and pediatric palliative care as families try to negotiate the various roles and various cultural norms that they're sort of trying to maintain and embody. And so I'm like, whoa, there's so many different different aspects that I am thinking about. So y'all, we have about 10 minutes. So if you want to either raise your hand if you have a question or comment, or type it into the chat box, and we can deliver them to Dr. Hsieh. And I had like several different questions that were sort of swirling through my head, but I'll ask a first question to kind of get us going. How do you make sure I'm articulating it well? When these different sort of ways of thinking about the world, magical, mythic, perspectival thinking, when we're encountering them in not in sort of public health campaigns, but rather in a more concrete clinical context, like a goals of care conversation, or trying to talk to someone, trying to I don't know if I want to say convince, but negotiate, getting someone to get a scan that we think would be really important for their health, and we're feeling kind of stuck. What I've heard people say is the best way to change someone's mind is not to play to the rational part of them, but rather the emotional. And to do so is to out narrate them. And that's in some ways what I feel like you're saying, which is like to connect their story away from a certain community and perhaps to their family. But what do you think about this kind of idea of out narrating someone's previous narrative in order to achieve a kind of different story? But then that also feels coercive.
Yeah.
And when you're sort of also saying like, and which I agree with for the most part, like there's not a better culture and a worse culture. So how do you kind of negotiate that in the kind of more one-on-one context?
I think first is you want to understand, what cultural perspective they're holding, because it is perfectly reasonable if there's a perspectival thinker who says, "I can't accept vaccine because it is clinically, I do not have enough scientific evidence," right? And so if and so you have to listen to their narrative to say, do they really mean it? Sometimes people really mean it, and then maybe that's you just don't have the evidence. On the other hand, sometimes people can say that, but that's really a mythic narrative. It's just sort of a scapegoating that they're saying rather than they truly feel.
I'm like bad faith.
Yeah, and I think that that's the part where you really need to sort of navigate and trying to say the differences between how can how can I adopt integral fusion as without being sort of perspectival, because like you said, perspectival, like I had a doctor who described all the procedure, including the size of instrument that they would use to remove cancer cells from a 90-year-old person. And after that description, you were like, yeah, I would never like have a baby. Like the core of that description make that patient say, okay, I will not have that surgery. And that's happening under, and that's kind of like, you know, the concept of out narrative, right? But I think that that is coercive. And on the other hand, integral fusion, we're really trying to understand what drives the decision making. What are the mythic value you're holding on dear that is prohibiting you from decision making? So one of the recent movie from Farewell is that a Chinese family, Chinese American family, not decided not to tell grandmother that she has terminal cancer. And, you know, the American daughter was very upset and say, you know, grandma has the right for self decision making. She need to tell us how she wanted to die, you know, how take care of her affair. And the father said, it is our burden to bear. You know, you may think it's easier to let her decide, but this emotional burden that she's dying is for us to bear. And I think that for a physician who is super into informed decision making, patient need to know, you know, to prepare for her end of life care, that would be very hard to understand, right? Because essentially the doctor and the patient are patient's family are holding different value system, like, you know. And so how do you reconcile two different value system when you're thinking about, I want to out narrative the patient story? I think the questions, a good question to ask is, what is the my value to make these to decide that this is the narrative I want to sell? One doctor was talking about, you know, asking me not to tell patient these end of life information is to destroy my moral compass. And in that sense, you clearly hear that it's the mythic value that is driving the doctor's struggle, as opposed to, you know, should we tell or not, right? And so I think in that sense, integral fusion then ask you, the doctor and maybe the patient, to say, okay, what's the conflict here? What are the values? You know, you think that this is your burden to bear. It's, you know, the children's role to take care of father, and but the doctor feel like, you know, patient need to know. So how can we reconcile these? um, and I think that every context will have its own creative solution, but it also requires people to appreciate, to see these different values as equal, not sort of my value trumps yours, in a very sort of hierarchical sense.
I think that also allows us to have some humility, because we can turn this on ourselves, like you just said, and ask whenever we hear ourselves really making strong claims or feeling distressed about sort of that we're under threat in some sense, then we could look at ourselves too. I'll turn to Dr. Coleman to ask a question. I see your hand up.
Thanks, Tyler. Thank you so much for that great talk. It was just so thought-provoking. And like Tyler, I also have your book, and I'm excited now to go back and re-understand it, and I think in some different ways. I would just, I know we're short on time. I think I'm hearing the integral fusion concept, and in my mind, it's sounding related to or similar to the idea of cultural humility. That idea about trying to remain open to the validity of another person's perspective. And I was wondering if you could just help me understand the differences between those two concepts.
Yeah. So cultural humility is to recognize, like, my culture doesn't trump everything, right? But integral fusion is really an effort to integrate differences in cultural perspectives. So it's not just inward looking. It is really a fusional process. So as you encounter differences, and you know, going back to what Tyler said, I totally agree that if you don't know what is holding you back, right, what's driving your decision, that you can't really fuse. But if you know, like, okay, I really care about this, you really care about that, can we find a common solution that both of our, we're not getting 100% of both what we want, but can we find a mutually agreeable ground that this works? So, you know, like Chinese father often wanted to, like, they may not want to take care of their affair, but instead of saying, don't, they would say, don't tell me how many months I have left, but if it's time, tell me that you want to take me to go visit my old friends, and I get it. And so there's a way of communicating that is mutually sort of both figure out that this is, both are sort of finding, both are, so it's evolving, right? So as time goes on, when you work with a different patient, in the beginning, you may communicate in a certain way, and later you may communicate in other ways because the patient has changed and you have changed. And so it's the ability to continue to recognize that the shifting grounds of values, of priorities, and be willing to adapt and accommodate, but also recognize the values that you need to hold strong. Because I think sometimes cultural humility can lead to, sometimes people misunderstand it as cultural relativism. Everything goes. And that cannot be the goal, right? Like there's got to be some essential values that you hold dear. And so, but then how do you negotiate when a doctor feels like not telling patients how many months they have left is destroying my moral compass? Then there's no room for negotiation. But how do you find a way to say, okay, if I feel so strongly about it, is there a way to compromise? It's a way for we to perform, to tell the patient without telling the patient in the way that you detest. And so I think that, so in that sense, integral fusion is an active behavior, trying to negotiate and create and generate a common ground for that immediate situated communicative context. It's not a permanent solution. It's a localized, the way you interact and create your integral fusion with patient A may be very different from patient B because they have different values, and different values are at play. But that doesn't take away your desire to find a fusion that works best in that particular patient or context.
Thanks. And if ever, I think what we'll do is, if you need to go, you can go, but I want to give Dana, Dr. Goldsmith, a chance to ask one last question, and then we'll wrap it up and give a round of applause after that.
Thanks. Elaine, it strikes me as you're speaking in response to that last question that part of understanding this has to do with understanding culture in these more dynamic, fluid, and even contradictory ways. That if we recognize that culture may have multiple values, then there's room for us to find the overlap between yours and mine. Or if we acknowledge, some of your COVID examples made clear that when we're talking culture, we're not just talking national culture, right?
Right.
And so if we think about people having membership maybe in multiple cultural communities or multiple identities, then it's a process of thinking about how do my multiple values and identities maybe find some intersection with yours. And so that we're not stuck with relativism as, well, you are who you are, I am who I am.
Right.
So I don't know if there's a question in there, but it just really struck me the power of some of the things you said very early in the presentation about culture, and wonder if you want to elaborate a little bit on that.
Yeah, that's totally true, right? And sort of everybody has multiple identities, and we can call out specific identities. If you think that you're a vet, right, you may act in a certain way, versus when I start to make you think that you're a father, then you may act in a different way. I think when I deal with magic, mythic, perspectival cultures, some of the most difficult thing to answer is really, what do you do with magic communities' health behavior? Because magic communities is a dominant identity that does not shift all around. It doesn't shift, because once you're in that magic community, a mother may even turn on their own children, right? So if you I use a cult as an example, but if you join a cult, you disown all other identities become irrelevant and doesn't influence your behavior and decision making, regardless how close you once were. And so magic identity is the one that truly dominates and then will dictate all behaviors. And whereas mythic, I think that there's a cultural identity shifting that you can manipulate from a doctor's perspective or communicator's perspective. Magic is kind of an interesting scenario to say, how do I communicate with people who just, are holding a magic identity, and they're not reflective, and cost is irrelevant to their decision making. And so maybe I don't have an answer for that just yet. I think that's the part where, you know, there's no identity shifting at all. Unless you leave the cult and then everything works.
Be the title of your next talk, Leave the Cult, and then everything works. All right, well, we are going to wrap up. That was, I almost want to I feel like Cliff and others who are at OHSU or in Portland, we should almost have some kind of follow-up where we read a chapter and have a small group discussion, because there's truly so many things that I'm thinking about. But everyone, please give a round of applause for Dr. Elaine Hsieh, who I'll be considering this the topics of this talk for a long time. Thank you for joining us. And as Dave Hoyt put into the chat, our next OBHC will take place on June 2nd. You won't want to miss it. It's Dr. Estela Vasquez Guzman from OHSU, a sociologist who will be talking in the Department of Family Medicine. We'll be talking about dismantling, decolonizing, and deconstructing to achieve equity, diversity, and inclusion. Thank you all for joining us, and we will see you next time. Have a wonderful May Friday. Take care.